I guess I would say two things. One is I think we should try to do more of an inventory of what's out there and then begin to put together the logical combinations as opposed to spotting gaps necessarily. And I would go outside the traditional boundaries of dementia work because, as we've said before, these are individuals who have multiple chronic conditions. And I mean, there's a world of evidence-based programs in mental health and in physical health. And I think many of them are very compatible. But I also think we need many more effectiveness studies, meaning studies with larger, more diverse samples that still have control groups in different kinds of communities and different kinds of organizations. I feel like we've jumped from small efficacy studies, which are not very generalizable, to broad implementations without the in-between of really understanding how you can serve different populations in different contexts with larger, more diverse samples. So I'd like to see both those things happen.
Yeah, I think the other piece that I would add would, because I agree with both of what my colleagues have said so far, I think the only other piece I would add would be testing, in particular, finding ways to we talked earlier about comparative effectiveness and finding ways to add in pieces. So taking the transitional care model and adding it into the patient-centered medical home is something we're piloting now, and finding how, if we add it in at a certain time, what will that do? And including patients with and without cognitive impairment, do they look different versus patients who are just who don't receive the transitional care model? Or testing it in other settings, in the long-term care settings, nursing homes, assisted livings, and other settings, and finding ways to improve care and also bring in the other services that are out there and better connecting them. I think that's critical. I think that one of the biggest problems we saw in the immediate time frame, the 3 months, the 1 to 3 months post discharge, was the need for the caregivers and their, the hospitalization and the burden at that moment in time during that hospitalization, and the importance of assessing it at the hospitalization and trying to find services not just for the patient when you transition them home, but also for the caregiver who isn't the patient, and discharge planners aren't always thinking about that. So I think there's an area there that we need to think about to make sure that they know what other additional services are out there that they can make referrals to, because I do think that they're assessing for it. I don't, or they're not directly assessing for it, but they see it. They just don't necessarily know always how to make that best, again, it's my opinion, what that referral might look like, because the patient is their priority.
I have the microphone now. Yay! I just have a few comments. One, this was really great, so I'm all jazzed up about what you're saying, so thank you. One thing that I wanted to comment, Chris, about something you said that really resonated with me about the MRIs and about ordering, how easy it is to order procedures and MRIs, et cetera, and this is readily accessible, and the dollars behind that. But also, I find that physicians, they don't say, oh, Chris, would you like an MRI? It's not, we could do an MRI, but, call this number and go ahead and set that up, but if you want. But this is how our programs and services are offered to patients. It's not, okay, the first thing we're going to do is you're going to get an MRI. And you go down to the scheduling nurse and she's going to set that up for you. We got to think about how to routinize that kind of thing so that it is easy for physicians to say that, and it's not like a, would you like an MRI? It's a, you're going to have an MRI. Basically, I feel like for dementia, non-drug treatment of dementia, it's very like, this probably doesn't work, but if you want to do it, you can. Here's a number, can't hurt. And I just wonder also, what is the role of the electronic medical record in helping us to get this sort of institutionalized, and is there anything we can do there? And in Minnesota, I've been in a lot of conversations where people are talking about dementia as an organizing principle for medical care, so that if someone is diagnosed with Alzheimer's disease or a related dementing disorder, it becomes the principle upon which all of their care is organized. It trumps everything. right now, I think if you have diabetes or COPD or something, that trumps everything. But really, if you have cognitive impairment, you can't take care of any of these other things. And so it becomes sort of an organizer for how care is delivered for all chronic conditions if dementia is present. So these are just things I throw out. I don't know if you want to talk about EMR especially, or if you did anything special with electronic medical record that helped you.
I have no idea what you're talking about with the doctors and the MRI, for the record. No, so part of what I would say though about that issue is the doc does have good confidence what he's going to get when he orders or she orders the MRI, and knows the report's going to come back, and is really not responsible for anything but getting the results back. And I think that is part of the problem with these other services is they haven't, for all the reasons that we've talked about, become that reliable. It's really frustrating when you do have one of these agencies that you've been using, say, for 3 or 4 years, and they're literally gone overnight. That never happens with a MRI or another test, so that's part of it. We do, the longitudinal tracking that everybody's talked about, that notion of taking care of a population, that's where I think the EMRs have their real strength. That most of the EMRs are developed to take care of a single patient at a time. A lot of these programs, in order to do the supervision that we're talking about, you need to be able to open up a screen and it shows all of the cases, who saw them last, what the PHQ-9 was, or the behavior checklist, or, what medications they're on, so that you can then go, well, what's going on there, and call that, particular care manager to find out what's going on. The care managers also like it in terms of designing their day. Who did they see last, and, what was their last scale. So I think those are, for our intervention, it was a big part of the intervention.
I have just a short comment, which is that as I listened to you talk about the doctor orders an MRI, and I have this herniated disc now, and I walked into the doctor's office and he said, first you're going to do this, and then you're going to do this, and then you're going to do this, with great certainty. And then I looked, because I'm a researcher, in the literature to see what evidence there was for all those things he was telling me to do. And he's really certain, and there's hardly there's anecdotal evidence. He saw a patient last week just like me. But we don't have nearly the same, we don't speak with that kind of confidence. If you ask me what exactly does the NYU Caregiver Intervention do, and I want to be totally honest, I'm not sure I would be so assertive and say, this is what it's going to do, in the same way that orthopedists told me exactly what to do. So I don't know how to change the mindset. It's not only, I think, the mindsets of all the people I listed this morning, the patient, the family, the doctors, it's also the mindsets of the people who develop and deliver these interventions.
Thinking about what we've been talking about all day, it seems to me that Laura has said several times and in different ways this concept of the standard of dementia care, and Michelle built on that. And to me, each of these three intervention or systems that we're talking about now basically creates a system or a care system within which many of the individual interventions, the family caregiver ones and some of the ones we talked about first for individuals, could be embedded. So they're a connection with the person, an ongoing connection with the person, and a framework within which you might try any of these programs. So, does anyone here not like that idea? Can I say, this is what I'm asking you specifically. I'm hearing this over and over. I'm writing the draft white paper. Is it a consensus of our meeting, that this is where we are right now. So we have interventions, we need a frame within which we would determine who needs which of these and when, and we hear several frames here. So disagreements.
I don't have a disagreement, but I would say that I hear a lot about people saying, oh yes, and this will be delivered by, nonprofits or other, like the Alzheimer's Association or other, even the AAAs. And I just want to be very cautious about that because I don't think we can depend on sort of charity or whatever for at least this first level that you're talking about. I think it has to be embedded within, at least initially, the medical system and reimbursed by that system initially.
Okay. Does anyone really disagree with what I said? Is it a consensus?
I agree. I just want to say, I don't know that we have all the interventions.
No.
Right, but
I think we've
Yeah.
said that. We don't have all the interventions, but we need a frame.
yes.
So,
It's difficult to disagree with what you said, but I think there's more to it. It's sort of like what we talked about before. It's like,
What good does it do to think about cataloging it when we've got to find more cost-effective ways for dissemination to improve scalability of these kinds of things? And so there's a larger frame, I think, perhaps.
I agree with you. It strikes me, David, that the kind of things that you do in the consultation over the long term is sort of the thread that could run from the very beginning to the very end. And that people need to come in and out for these different interventions because they all have different time frames, different eligibility or inclusion exclusion criteria, different kinds of outcomes that you're looking for. But there should be an assessment of the process from the beginning to end with, I used to think, well, there might be a caregiver assessment that includes all of this. But actually it was something that you said, which was, it started me thinking, there should be assessments, there should be assessments that are titrated to the setting, but also to where people are in this continuum as well. Because the assessment for a very early stage is very different from middle and end stage. And there needs to be a commonality, a core coordinator. We're talking about case managers, I heard that word. But there needs to be a core set of competencies and standards. And what you're talking about is sort of, to me, is almost like a practice standard, or the thing that should run through and grab these interventions when they're appropriate for each, for the family. So I agree with you, Katie. Maybe that's a different way of saying framework. But I think that we can't have these interventions out there sort of randomly floating. There needs to be some consistent way of coordinating them to families as well.